friends, Dave Bjork here, lung cancer survivor, patient advocate, and yes, I'm the Research Evangelist. And welcome to the Research Evangelist Podcast. You know, the Greek meaning of evangelist is bringing the good news, and I like to think that I'm bringing the good news by sharing stories of people in lung cancer research and care who are doing amazing work. I call them brilliant but not famous, and well, the irony is that they're all brilliant and well-known and respected in the communities that they serve, but my next door neighbor probably wouldn't recognize their names. But they truly are awesome people, and I love sharing their background, their work, their passions, and their story because everybody has a story. I also believe in serendipity, so I hope some good will happen by me sharing their stories with all of you and to the universe. So today I am super excited to have on my show Dr. Janani Reisenauer. She's a thoracic surgeon and interventional pulmonologist at the Mayo Clinic in Rochester, Minnesota. She received her medical degree from the University of Alabama. She did a residency in general surgery and then two fellowships, a fellowship in thoracic surgery and a fellowship in international interventional pulmonology, all at the Mayo Graduate School of Medicine. So excited to hear your story. And Dr. Eisenhower, thank you for being here and welcome to the program.
Thanks so much, Dave. It's a pleasure.
Awesome. It's great to see you. And we're getting late spring, so we're getting ready for the warmer weather to come for places like Minnesota and Massachusetts. So, but that makes me think of let's have you tell us a little bit about yourself because I know you're from Alabama. So, tell us a little bit about that because that's not Minnesota for sure.
No, it's not at all. So I went to medical school at UAB, which is in Birmingham, Alabama, and surgery was not on my radar. Many people talk about how they wanted to be a cardiothoracic surgeon since the day they understood what that involved. But I was quite the opposite and went all over the place. Initially, I thought maybe a neonatal doctor, pediatrician, all kinds of things. I was all over the board. But what struck me about surgery, what I really enjoyed about surgery was when I rotated in thoracic surgery as a medical student, and these patients would come to the OR with fear and anxiety around a cancer diagnosis. Um, it had impacted their life in significant ways. Many of them had to give up working or give up their way of life because of this disease. And you could take a patient to the operating room and do something about that in a matter of hours and give them their life back. And that to me spoke volumes. And it was so much more compelling. That immediacy of relief, that instant gratification, and that immediate translation to the patient in terms of not just quantity of life, but quality of life. And so, as somebody whose surgery was nowhere near on my radar, that spoke volumes to me. And that's what prompted me to think about going into surgery. And at the time when I was applying for surgical residency, my mentors and my advisor said you should really look at the Mayo Clinic because it's one of the top training programs in the country for surgery. And I was reluctant to do that because it was so far away from home. There's so many cultural differences, as you might imagine, between Alabama and Minnesota. And there was not, no offense to any Minnesotans that might be listening in, but there was not a very strong college football team like what I was used to coming from the state of Alabama. So there was a lot of anxiety about thinking about it. But I did decide to put in an application, and I came to Mayo for an interview. And when I witnessed the culture, the compassion, and the commitment to patient care from every level, not just the surgeons and not just the nurses, but the people that served the patient's food in the hospital, the people that cleaned the rooms after the patients were discharged to make it ready for the next patient. There was something really special about the culture here, and I knew that by coming here, I was going to become I was gonna be able to exercise any potential that I had because of the environment and the training and the mentorship and the skill set of everybody here. And so I was a convert, and to Minnesota I came.
That's awesome. Well, that's really great to hear, and I'm not surprised to hear that. And I'm very familiar with the Mayo Clinic, growing up in Minnesota myself. Interesting, you mentioned the impact of uh, the mentorship and deciding to go into surgery, and how you felt about being able to help a patient immediately. And so, how did you end up with in cardiothoracic versus general surgery where you were trained?
Yeah, it's a good question. So, when I was in medical school, I actually rotated with Rob Cerfolio at the time in Birmingham, who was starting to just do some of the robotic training at the time, and so it was firsthand exposure to thoracic surgery and something about the big, complex nature of those cases being in the chest, the anatomy, I think really resonated with me, and he was a great mentor, and I think so it was a combination of the environment, the mentorship, as well as the anatomy and the specific surgical field. When I applied, though, I applied to just general surgery. I didn't apply to a cardiothoracic integrated program. One, because those didn't exist at that point in time, but also because I didn't want to make sure, I wanted to make sure I wasn't boxing myself in too early. And I said, let me just get exposure to all components of general surgery and then I'll decide. And so when I came to Mayo Clinic and rotated in thoracic surgery and worked alongside some of my mentors there who are now my partners, many of them are my partners. Um, Again, I was enamored with the complexity of the operations, but the simplicity of the anatomy around the complexity of the operation. It seems like the ultimate paradox, but that's what I liked about it. I also liked, even then, thoracic surgery was such a complex interplay of not just technical knowledge, but medical knowledge. Like you had to understand the nuances of chemotherapy and radiation therapy and timing and sequence and where there's multiple pathways that might make sense for a patient, what's right for this specific patient. And so it wasn't just purely technical. And that part I really loved about it. And it's always been very collaborative in terms of interfacing with the oncologists as well and the radiation teams and the pulmonary teams. So I think that's what I really enjoyed about it. And looking back on it now, it was a really, really, I'm so happy with that decision.
That's great. That's great. And so, why don't you tell us a little bit more about this dual program and why interventional pulmonology is so unique? I think I read that you were the first dual fellowship trained and board certified in a program such as this. Is that true?
That's true. That's true. There are surgeons out there, very famous surgeons, that have become cardiothoracic surgeons and then incorporated interventional pulmonary into their repertoire of procedures and operations and things like that that they offer. But at the time, knowing where the future of lung cancer care was going, recognizing that more and more and minimally invasive approaches will become more pervasive and the paradigm will shift, there came an opportunity to do a dedicated interventional pulmonary fellowship at Mayo with the interventional pulmonologist. This was about a decade ago, so it was still a relatively um, novel concept as it related to things that were taking place in the interventional pulmonary field that directly related to lung cancer. But my mentors at the time told me, look, if you're trained on early diagnostics and early intervention, then you have a unique skill set in being able to not just treat everything with a scalpel, but if one day treatments become available through a scope, you're proficiently trained and not just with on the job training, but you've been through a fellowship, you've sat for the board, you're board certified, you won't be able to be questioned per se in your proficiency and capability and competency to be able to deliver those procedures from both sides of the drapes. And so it was a little bit of a gamble. It worked out well at the time because my husband is also a physician. And so he was finishing up a year of fellowship anyway. So from a timing perspective, um, naively, I thought, well, I need something to do for a year. So that's part of the reason why I did it. And now looking back, it was like the single greatest risk I took, I guess, for lack of a better term. But at the time, I wasn't so scholarly in my approach. I just needed something to do for a year. But my mentors were the ones who had that foresight to say this is where the future of lung cancer is going, and you will be, uniquely skilled if you take the extra time and do the training and learn from the experts in that field. And I'm so grateful for that.
Yeah, now, so since we've been talking, I believe you've mentioned mentors, 4, 5, 6 times, which
Yeah.
I love because I love mentorship and I love hearing stories in medicine of the impact that people had. So it sounds like you had a trail of these mentors that kind of led you to this path, although it may seem like it was this naive decision, because you needed something to do for a year. It actually has turned out to be you're brilliantly uh, uh, set for some of the future. And I'm going to ask you about that, some of that research that you're doing as well. But I did want to make sure that we hit on the mentorship piece of it. And I think that you're probably, I know you are, because everyone I interview, they appreciate and um, respect the people who mentored them. But then now you're going to be mentoring, if you're not already, you probably are already, the next generation of people coming up through. Then, what does that feel like?
It's really rewarding because I think the onus on a mentor is not just to teach somebody how to do thoracic surgery, but it's how to be a good physician and a good role model in general. And to me, is a really unique opportunity. I had my first child when I was going through cardiothoracic residency and fellowship. That was not easy. It's hard enough to do a cardiothoracic fellowship, let alone have a baby in the middle of it. Um, and there was unique that was a unique experience, and there was some trials and tribulations along the way, but I felt incredibly supported by the people around me, and that's what allowed me to get through that. And we're I feel like a moral and ethical obligation to pay that forward to the next group of people that come forward too, So, what good are we if we aren't leaving behind a legacy that somebody else can pick up and evolve and make better, and then carry on to the next generation themselves?
And of course, when we talked the first time we met, we talked about Doug Matison, Dr. Matison, who was my surgeon many years ago. And the impact that he had on the field of cardiothoracic surgery is pretty cool. For me to be so grateful to be treated by someone like him, who was such a legend in the field. So I'm sure you appreciate those types of figures, that handed down to the next generation. I just think it's really cool that you all appreciate that. So, and you talked about this colla collaboration, from your perspective and your training. Tell us about the collaboration. I think I read that you or maybe you told me that you do, like, they have tumor boards, like, every day instead of, like, every 5 days. And tell us first, tell our listeners what a tumor board is, and then tell us about the impact of the collaboration that you have with the team at Mayo Clinic.
Sure. Lung cancer is it's an interesting space because even 10 or 15 years ago, it was if you were stage 1, you got surgery. If you were stage 2, you got surgery and then chemotherapy. And then everything above that was essentially non-operative. And so much of that has changed with new treatments, immunotherapies, targeted therapies that really almost every cancer patient benefits from a multidisciplinary approach. And especially being in a place like Rochester, Minnesota, where yes, we get patients from around this area, but we also get a lot of patients that are taking time away from work and traveling and flying into town. And, the onus is upon us to make sure that when that patient comes, they see everybody that they need to see. We're all on board with a plan ahead of time, and the patient doesn't feel like they're getting conflicting information from their different team of specialists. I think it gives them reassurance and confidence that they're in good hands if everybody that they meet with says, "We've discussed your case. We are in agreement that this is the right approach. And this is your time to ask us specific questions about our area of expertise, but we've all agreed on the treatment plan moving forward." And that's essentially what a tumor board is. It's an opportunity for all the relevant experts to convene and review a patient's specifics and say, yeah, we're going to agree that scientifically and collaboratively this approach makes the most sense. It allows us to also consolidate a patient's itinerary because I can't imagine how devastating it is for a patient with a cancer diagnosis to be flying back and forth just to get a plan in place for their team members. So, um, that's the intent of a tumor board. We're privileged that we actually have a half an hour carved out every day where we discuss patients that are coming to Mayo Clinic. So we have kind of a daily tumor board. Every other week, we have a broader tumor board where all Mayo Clinic Care Network members can join. So this might be a hospital that's in the Mayo Clinic Care Network, but not Mayo itself. They can actually send us their information and we do almost an external review. If they've got a consult, are we managing this patient appropriately or not? And they get a multidisciplinary team review where we review the pathology, we review the radiology images, we consult all the specialists. We do that formally and officially every other week, but informally, we as a group meet every single day for 30 minutes and do that. And again, the goal is just to make sure that the patients have an architected plan that gives them the confidence that we're all on the same page and we're all recommending the same thing.
Yeah, and from a patient perspective, I can tell you how much that would be of great comfort, to me, to know that there's multiple sets of eyes looking at my case and not just one physician, who is quote unquote making all the decisions. I've been doing a series on shared decision making, how important it is, that the patient and caregiver voice is also, part of that conversation. But I love the fact that the review and getting prepared to receive patients into the Mayo Clinic, I think is very cool. We talked when we met, about how other places might not have the resources, of a Mayo Clinic and how important that is. So one of the things that you touched on was these, not just the local people, but the people who are coming in for as referrals or for second opinions or whatnot. And can you kind of tell me about some of the work that you're doing to try to um, work in under resourced communities, and I think that I'm sure as much as part of it is having these services available to, to be able to connect with outside of the local Mayo Clinic community. We talked when we met, how do I help my relatives who live in, War Road, Minnesota, up on the Canadian border, to get access, to something like the Mayo Clinic without, to your point, without having to drive 300 miles back and forth, to get to Minneapolis for that. Um, so tell me about sort of why it's important to you, and what kinds of other things that you're doing in under resourced communities.
Yeah. I mean, I think it's so important because a person's disease is just one aspect of who they are as a human being. There's so much more beyond just the disease that shows up on their insurance forms as their ICD-9 or ICD-10 code. There's a human being, behind that diagnosis. And that's a human being that might have to work to support their family. It's a human being that might have young children. It's a human being that might be taking care of their elderly patients. There's so much to that beyond just the disease that gets put in the medical record that we're assigned to review. And so to me, how Mayo Clinic can help these patients is not just about what happens when they show up on our doorstep, but what we can do even beyond. And I think Mayo Clinic has invested strongly in ways that we can help patients from even what we call outside our walls or care beyond the walls. So that's a program that um, is a very strong initiative at Mayo, is to figure out who really should be coming to Mayo that we can help on site, and how can we extend our treatment plan and recommendations and collaborations to patients that can't come on site or don't need to come on site. And so for those that do need to come on site for complex or serious treatment, the mechanisms are in place such that we request the records ahead of time, we review the records in tumor board, we come up with a plan, and then we try to condense an itinerary for the patient so they have to make as few a trip as possible. And again, our goal is to really expedite the time from when we hear about the patient to getting treatment on board as soon as possible. And that's where doing some of that work in the background and getting everybody on board makes a ton of difference. Um, in terms of even research and clinical trials, we're looking at ways to create clinical trial matching so that we can screen patients even before they come to Mayo Clinic if there's a unique clinical trial that patients are candidates for, that they're aware and notified so that they have access to all the cutting edge clinical trial and research opportunities that they might be candidates for and available to them. So much of that work is on our 2026 radar for improving clinical trial opportunities for patients that are coming to Mayo as well. So that's just a couple of examples of things that we're trying to do to touch patients around the country and around the world.
Yeah, and of course, the clinical trial, getting the right patients into clinical trials is such an important and much needed activity because many of us know, how few people are actually participating in clinical trials, and how do we find these patients and get them connected to to the right place is such a huge challenge. So I applaud you for putting that as also as a priority in your practice as well as within the institution. So um, you mentioned clinical trials. Now, you also mentioned about maybe the potential for delivering treatment through scopes, and I read that you are doing some work in this area where delivering breakthrough treatments through like bronchoscope, which I think is really interesting. Now, of course, I've had a few bronchs in my day, which it's not really that fun of a
No.
procedure, but I'm really interested to hear you tell us about that work that you're doing.
Yeah. So there are multiple technologies that are starting to emerge to treat tumors through the scope. Um, the umbrella term for that is ablation, but really what that means is poking a tumor either from coming in from the outside, like with a needle, like somebody might get with a CT guided biopsy, or now more novel and more recent in the last few years through the bronchoscope, where you can puncture the tumor and deliver some form of treatment to treat that tumor. There's a variety of modalities that exist. Some are using extreme heat, let's call it, or microwave ablation. Some use extreme cold, called cryoablation, and then some use electricity, called pulsed electric field ablation. And we're fortunate enough to have participated in clinical trials looking at all of those. We're still very much on the precipice of what that could look like in the future. We need good clinical trials and scientific data to understand where that is going to work either in concert with other therapies or in replacement of other therapies. We need some good scientific data to understand that. But where the world and the community is at right now is designing those clinical trials and studying the efficacy of those treatments. I think one of the hardest challenges that physicians encounter is just because there's a treatment that's come on board, who is the right patient to put on that treatment? Because we know in some circumstances, there is one treatment that's probably better for patient A than for patient B. And when you have the scientific data to make that judgment, that's a lot easier. But when you don't have that scientific data, how do you pick the right thing for the patient? And so again, this is where designing clinical trials around these things so you can study them scientifically and so that you have an open conversation with the patient so that they know all their options and what they're a candidate for and what they're not. There's still a lot of work to do there, but I think most of us that have started to see the early adoption of these technologies thinks that there is a significant future ahead where we may not be treating all cancer with surgery moving forward. I'm curious to see where that goes in the next 10 to 15 to 20 years.
Yeah, yeah, and you mentioned the options, that patients have now, and you mentioned, 10 to 15 years ago when, it was surgery, it was stage 2, it was chemo, and then if it was above that, it was, there's nothing we can do really, right? And so think about now having conversations with patients as again, I'm a research evangelist, but I'm still not a scientist. So, but for me to understand, to because I'm part of this bringing the patient voice to, treatment, drug development, treatment development. I think it's important to patients to understand that there are different treatments that are available now, and the patient and you. I love how you talk about it's a personalized approach. Like patient A and patient B are not the same people,
Hmm.
and so the things that might matter more to patient A might not matter as much to patient B or vice versa. And so I see these treatment well, it's like just blows my mind that we actually have now in certain areas. There's actually multiple choices that patients have in what and patients and their physicians, to make the decision of which treatment to take. So I think it's very exciting. This is a very exciting part of research that you're doing. I think that's really cool. So
I
what
agree.
you know, you're also, I know you also, you know, you're an innovative thinker and you're involved with some other things as well. What innovations beyond what we were just talking about are you most excited about?
Yeah, it's a great question. I mean, I think um we've talked you mentioned personalizing, right? And I think there's some component of personalization that is upon a conversation between the patient and their doctor in terms of who are they as an individual, what are their um, social factors that might make a difference in terms of where they live and their occupational status and all of those things. But then there's a scientific personalization component too. 10 years ago, 15 years ago, it was cancer, yes, no. And then it became small cell versus non small cell, yes, no. And then it became adeno versus squamous, yes, no. And now it's PDL1 status and EGFR status and ALK mutation status. And we've gotten to the degree of looking at it on a mutation basis. And Mayo is now doing even research to look at what's happening around that tumor. We call it the tumor microenvironment. So, what are the various cellular and molecular signals that are turning on and turning off? And how can you manipulate the immune system to better respond to treatments? Because if you give patient A and patient B the exact same treatment, why does one patient respond differently than another? Why does one patient recur and the other patient doesn't? What are we missing about the host and the host's immune system that recognizes the cancer versus doesn't recognize the cancer? So this is where I think the innovation gets really exciting because human capability maybe could not understand that to a depth that the way AI can today. And I think the incorporation of AI will allow us to detect these signals and these changes in a way that we've never really been able to do so before. And with the amazing power of AI and compute and reasoning and seeing beyond the naked eye, so to speak, I'm hopeful that we can start to see trends and signals and patterns of behavior, both within but also around the tumor, that allows us to get even more personalized so that we're not guessing, but we're forecasting how somebody is going to respond if being given treatment A versus treatment B versus treatment C. And then my job as the physician becomes to explain to the patient all these treatments, yes, are reasonable, but what our forecasting tells us is that this one might be a better approach, and here's why, versus this approach or that approach. And then one of the big things that I'm really passionate about is having that open conversation with the patient so they really understand what they're signing up for and the risks of what they're signing up for and why we decided as a team to choose that treatment path.
That's so interesting. There's so much there because I have um, a friend of mine who's a basic research scientist. He's epigenetics. He runs the epigenetics center at Fox Chase now, and he used to he'd get so passionate talking about his research. He's like, Dave, is that it's the microenvironment. It's RNA. And I'd be like, I have no idea what you're talking about. I have no idea. So because I'm not a scientist, but he gets just as excited about it as you do. And some of the work I'm doing with metadata, it's been interesting we just had a project where we're looking at these different simulations and using AI to sort of like these predictive models. And I'm just learning myself just about how, you know, how does that actually work? People think of AI that they think of like, maybe I can use it to write a term paper or something, but it's like when you think of it in terms of science, or you think of it in terms of a clinical trial, or decision making for patients, I think um, it's going to be interesting to see where it goes. But I'm already starting to understand it better because it's not gonna be the decision, but it might be, it might be part of that process of probabilities and likely outcomes, or who might be better eligible for a particular treatment than others. So I'll leave it for all you scientific brilliant geniuses to figure it out. But I love hearing about it. I really do, and I think it just gives, patients, um, more of those options. Um so I'd love to just keep going and talk because you've such interesting work that you're doing. But I have one other question I want to ask you, and I ask everyone on my show. Outside of work, tell us something about yourself that you're passionate about, or that people might not know about you.
Oh boy. Well, It's funny. If you would have asked me that question 10 years before I had 3 children, the answer might be completely different than what it is now. But I have 3 children. They're wonderful. They're very engaged in all kinds of extracurricular activities. So, um, I tell people the thing that I want to most be known for is my children's accomplishments more so than my own. So that's where I heavily invest my time. I did go to college on a theater scholarship. So, um, it's just an interesting serendipitous set of circumstances that put me where I am today, and I'm super grateful for that. But music and theater and acting and things like that were always a passion of mine growing up, and I'm happy to see that a couple of my children have adopted that too. So we'll see where it goes. But most of the time these days, it's just about trying to stay afloat.
It's all hands on deck, isn't it?
Yes,
I mean,
yes.
I have 3 boys myself, so I know what that's like. So, but I love the nugget about the theater, because I had another guest who similarly had a passion for music and was or dancing, and so she was, as an adult, she was, kinda going back to it. So you never know, you might be doing Playhouse theater or something, down the road. You might become, in your second career, become famous as an actress, so who knows?
We'll see. Jury's out.
But anyway, it's been really great to have this conversation with you. I'm really excited to share your story. You have a great story, and I appreciate, how hard you work and all the things that you do. And I really thank you for all you do for the lung cancer community. So thank you, and thanks for being on the show.
Thanks, Dave. I would say the same to you. Thank you for everything that you're doing for patients with lung cancer. It's really meaningful work and it's so empowering. So thank you for giving the patients a voice. And this was a pleasure.
Awesome, awesome. Thanks so much.
Thank you. Take care.